Good evening, everyone, and thank you for attending our Physician Wellness webinar. I am Dr. Lynn Cintron. I'm the current president of the California Society of Interventional Pain Physicians, and I'm very honored to moderate this session this evening. We have three wonderful speakers, and we're very grateful for everyone's input, and we welcome our attendees from both in California and across the country. Thank you for attending both live and by recording. I'd like to first mention a thank and support from Valley Health, Medtronic, and Edwards Life Sciences. We are very grateful for their support for this webinar this evening. Valley Health is a digital marketing platform, and it provides support for physicians for online reputation. It also helps capture new patients and engage existing patients with automated technologies. Medtronic, as you know, is a global leader in medical technology, services, and solutions, and improves the lives and health of millions of people each year. Edwards Life Sciences is also a global company. For over 50 years, it has been helping make proactive clinical decisions and advance the care of surgical and acutely ill patients through monitoring. Our webinar will run till an hour and a half today. If you have any questions, please feel free to contact me by email or our speakers. And you can also have access to the webinar at our website at calsipp.com. And on physician well-being, this affects everyone. I'm a pain specialist and an anesthesiologist, but our audience is broad. And we'll have speakers that will address warning signs of burnout, self-care versus patient care, responding to adversity and resilience, and some other topics regarding this. I just wanted to mention a few statistics. Burnout, as you know, is high, especially for physicians in 2020. And there was a survey that was done by Medscape, a national survey that examined over 12,000 US physicians. And roughly 44% of physicians reported some degree of burnout. And it was higher in areas of critical care, infectious disease, pulmonary neurology, family medicine, emergency medicine related to the pandemic. When they were asked through the survey why do they believe they're burnout, and the majority responded that there were too many bureaucratic tasks, for example, charting, paperwork, EMR, insurance, appeals, etc. And when we asked these physicians how to help reduce the physician burnout, many of them mentioned increasing compensation to avoid financial stress, having more manageable work schedules, greater respect from their administrators, colleagues, staff, and increased autonomy, more support, more reasonable patient loads. And interesting, not having COVID patients was only down in the 5% range. So we have here a system problem, and that doesn't get enough recognition. And a study that was done by Brock Utney and Jaffe, published in JAMA in 2020, talks about reducing the bureaucratic impediments to patient care by reducing the bureaucracy itself. In other words, don't really blame the physician. The Medscape survey data did show that with regards to men and women, women were approximately 51% compared to 36%. So women had a higher burnout. That was related, in part, they found to increased home duties and family responsibilities. Now, why physicians don't seek help for burnout, we're going to talk about this a little bit more, but Many of them believe that their symptoms are not severe enough, 52% from the survey. 46% thought that they could deal with this without help from a professional. Many of them thought they were too busy. 20%, however, said that they did not want to risk disclosure. And this seems to be a very important topic. Physicians tend to suffer in silence. So I wanted to give two case examples in point. Unfortunately, these are tragic examples, but how burnout, depression, and the spectrum can eventually lead to suicide if it's not proactively dealt with. This is Dr. Corinne Dion on the left, and Dr. Lorna Breen. Dr. Corinne Dion, she was 35, emergency room physician in Quebec, and she worked very hard during the pandemic. She never contracted COVID-19 herself, but was under a great deal of stress. She, in fact, ended up taking a medical leave from work. Her husband said that she felt guilty, useless, ashamed, and in fact could not bear the guilt of being home while her colleagues continued to work and were overwhelmed. And she just died 3 weeks ago by suicide. This has made it apparent that the pandemic has made it more challenging for doctors in distress to get support. Frankly, none of us are immune. Some are better equipped at tolerating challenges than others, but physicians need to know that they are not alone and have access to more resources. And Corinne's family wants her death to serve as a wake-up call to health professionals that if they're in distress, they need to reach out for help. We need to talk about it more. We need to let people know that they're not alone. If you know of someone who is in distress, call them. Don't let them feel isolated. Let them know that they're cared for. The second case, Dr. Lorna Breen, may have heard about Lorna. She was an emergency room physician, again in her 30s, talented young lady, also a mother. And she contracted COVID, recovered, and her family thought that she returned to work too quickly. She continued to work long shifts with little rest. She died by suicide in April of last year. Her sister said that she suffered in silence and did not get adequate help because of the professional stigma, the fear of judgment from family, friends, and her employer. As a result of this, there is a nonpartisan bill that has been submitted to Congress. It still needs to be passed, called the Dr. Lorna Breen Healthcare Provider Protection Act, and it is geared towards establishing grant programs from the Department of Health and Human Services to improve mental, behavioral health and prevent burnout amongst healthcare professionals, nurses as well. Many resources out there, and some of the speakers will mention some of these. I just wanted to list a few so you have them at your fingertips. Physician support line, this is a number that provides confidential peer support by volunteer psychiatrists. They're exceptionally well trained, and it's available from 8 to midnight, 7 days a week. And these individuals are happy to talk with any physician about stress, anxiety, insomnia, whether it's COVID or non-COVID related. Other resources, the National Suicide Prevention Hotline, 800-273-TALK, the American Foundation for Suicide Prevention. They actually have a text number here, 741-741. CMA, California Medical Association, has a confidential line as well. Dr. Sartori, which is one of our speakers today from the Christian Medical and Dental Association, will talk about some of the well-being topics that his group provides. CSA, California Society of Anesthesia, also has many other apps and such for well-being. So there's a spectrum of resources, and I also highlight some of the work that Dr. Tate Shannonfelt from Stanford and his group have done on advancing physician well-being. So the message here today is you're not alone, and I'd like to start with our first speaker, which is Dr. Josh Kurtz. Dr. Kurtz is a clinical psychologist at Stanford Health Care and an associate clinical professor. He teaches, he lectures, he's well respected in the medical legal community. He works in the perioperative and pain medicine section. And I'd like to welcome Dr. Kurtz.
Thank you, Lynn. I will share my screen here. Thank you for having me. Let me pull this up. Okay, so this is me. We're going to talk about wellness, physician burnout. This is a definition that came from the Agency of Health Services and Quality, similar to the study that Lynn was mentioning. This is from 2017. They were defining burnout in this way: emotional exhaustion, depersonalization, a lack of purpose, a lack of accomplishment. I was shocked at how high the rates were. In this particular survey, I would have guessed 15%, 20%, which I would consider quite high. In this particular survey, it was 42%. Some of the other surveys are similar or even higher. I would also debunk that myth of, that doctors aren't as tough, like the old days. And it's an unfair comparison. If you were comparing a physician today to physicians 50 years ago, it's no contest. I mean, dealing with insurance, more complicated, EMR, reimbursement, dealing with reimbursement on a relative basis not being as high, and then simply the world being more complicated. You do 2 more hours of EMR after clinic every day, and then you get home, and then you're on parent duty. Like again, it's a night and day difference between today and decades ago. I would also echo some of what Lynn was saying about the culture of medicine. This culture of a lot of good things, of course: persistence, achievement, overcoming obstacles, but also independence and not asking for help. So it's really the combination. You've got all these external challenges, and then you've got this internal culture that can prevent physicians from reaching out and getting help when they need it. Some of the effects of burnout can range from more errors, higher medical costs, abandoning your career. If you abandon your career at 35, that's a problem for you. That's a problem for patients who aren't getting treated. That's a problem for society. There's a big expense in resources and training physicians. And of course, at the very more extreme end, the suicide risk. And if you think about it, the suicide risk is the most perplexing because physicians as a group have no risk factors associated with suicide. If you look at some of the common risk factors for suicide, they are things like, a major mental illness. That's not typical in doctors. Major addiction problems, sure, possible, but not common among physicians. Impulsivity, a pattern of impulsive actions, again, not common. Low rates of marriage or being partnered, quite the opposite. Physicians are more likely to be partnered or married. Unemployment, physicians are universally employed virtually. I mean, if you were looking at it statistically by risk factors, you would automatically assume that physicians would have a lower rate of suicide than people in the general population. General population rate of suicide is about 1.5%. So it's not a small problem. And it's been going up. That's, and some studies even show 1.7 lately. But physicians, it's double that. It's close to 3%. In the same survey, they asked doctors, I think this is almost identical to Lynn's slide, why are you feeling burned out, for the ones who are endorsing that problem? Again, too many bureaucratic tasks. As I said, I mentioned the average doctor spending 2 hours on EMR after clinic every night. That is not good for work-life balance. They certainly mention spending excessive hours at work, the charting, the paperwork, lack of respect from higher ups. I also work in the pain management area, like two of the people on our lecture. We have our own challenges. We're certainly not the only branch of medicine that has, you're just constantly around people who are suffering, they're in pain, they're depressed, they're anxious, they're scared. A lot of medical specialties see this every day. The problem is that, and this is a little bit harder, we don't have a lot of statistics on this part, but patients come in and they kind of unload on us. And they're not doing that intentionally, but they're getting everything off of their chest, and often, oddly enough, they end up leaving feeling better simply because of the therapeutic relationship that they have with you. So they feel that somebody's on their side, somebody understands. So even when you're not actually doing anything, there's no active intervention, they end up leaving and they feel better. So some of that diminished distress, that distress probably dissipates in the air, and some of it doesn't. Some of it actually ends up on us. I mean, we end up, I hate to say it, we end up being slimed. Like if you can remember Ghostbusters, and it's not intentional, the patients aren't meaning to do it, but some of that suffering and the emotionality and the depression and the anxiety, we end up containing that as patients feel better. And then it's incumbent on us to find some way to get rid of that ourselves. So whether that is meditation, whether that is going for a run, whether that's talking to colleagues, whether that's playing the piano, whatever it is that you do to help yourself feel better. And then, of course, you add COVID on top of everything that we are dealing with, and everything is just a little bit harder, a little bit slower, a little bit riskier in many medical specialties. And of course, we're a little more distracted by aging parents, kids who are being homeschooled, and then we can't even do a lot of the things that we used to do to blow off steam. So the gym is closed, and the theaters are closed, and the church is closed. So it's a tough spot. I mean, it's really I want to distinguish, when we talk about burnout, between some of the early warning signs and some of the later warning signs, because the early warning signs aren't necessarily dangerous. What they are is they're telling us that something is a little bit off. It's not returning phone calls, skipping meals, not sleeping as well, cutting back on some of our avocational pursuits, hobbies, exercise, of course, spiritual practices, and of course, self-medicating, a little bit more alcohol, drugs, what have you. Unfortunately, sometimes we move into some of these more later warning signs, more severe, more significant warning signs. We feeling emotionally numb, disengaged, withdrawn from others, more irritable, snapping at my staff, snapping at family when you get home. Quite a bit more reduction in activities like we discussed, but even more so. Persisting depression, and again, for some, a not insignificant number, even to the point of suicidal thoughts. I would add another suicide hotline. This is a 24-hour national suicide hotline, if you need. I also want to distinguish when we think about the things that can make burnout better, that can lead to greater levels of wellness. Again, two different kinds of solutions, one being kind of the external things, one being the internal things. The external things are essentially what work can do for you. The internal is what you can do for you. And really, when you talk about the external solutions, similar to Lynn's also, her slide too, this comes down to time, being able to control the pace, less time burden, but also values. So starting with time, I'm not going to spend a lot of time on this, but certainly, you know, when you ask doctors what can be made better for you in the workplace, fewer visits, more face-to-face time, more time with the patients, which is why I got into this in the first place, more support through staffing, more time set aside for doing EMR, for documentation, having MAs handle some of the EMR tasks, managing vitals, and offering, if your organization offers part-time schedules, flexible schedules. So at least these are not things that we can snap our fingers and make them happen. But these are the things that you can advocate for in your organization, and maybe you can achieve them and maybe you can't. But at least these tend to be the things that are associated with lower levels of burnout, higher levels of satisfaction. Values is tougher to describe specifically, except that, of course, when your values are aligned with your organization, you know it. And when they aren't, you also know it. When you feel that you're being, you know, just worked to the bone to generate billing and to generate profit, and patient care is secondary or tertiary, that doesn't feel good. You want to feel that the organization that you're working in has similar values that you hold. The internal solutions, at least these are things we can do these things ourselves. And, you know, I don't want to be the guy going around saying you have to meditate. I've got colleagues at Stanford, and every problem you bring to them, they say you have to meditate. And they're not wrong. I just feel that meditation's great and it works for a lot of people. I just feel like you have to find what works for you, because there's a lot of different roads that lead to Rome. Rome is wellness. We want to find what helps us get there. As a starting point, doing a good self-assessment, I think, do I need to make changes in my behavior? Or do I need some help of some kind? Do I need to improve my self-care habits? Do I need to change my practice in some way? Do I need to leave an organization that is not a healthy fit for me? Separating yourself from work, of course, we're not just physicians, we have many roles in life. Consulting with peers, like this lecture started off simply for the CalSIPP organization for interventional pain specialists in California. Great organization. Best thing about it is people talk to others who are doing the exact same work. Even if you're in private practice, you've got this group of cohorts that you can talk with. For myself, I'm half-time Stanford and half-time private practice. I love doing private practice, but it is so very isolating. So that's why I need the Stanford piece, which is very collegial, to balance out things for me. That's the right balance for me. You have to find, obviously, the right balance for you. I mentioned earlier about being at Stanford in pain management. In our world of pain management, and I know it's similar in a lot of branches of medicine, we don't get the big successes. We get small successes. So our patients don't walk in the door 20 years of pain, 9 out of 10 pain, 8 out of 10 pain, and then they walk out the door 0 out of 10 pain. That never happens. So, you know, if they leave, walk in 9 out of 10, they leave with a 5 out of 10, like we're jumping for joy. We're doing jumping jacks. Incremental success stories are still very meaningful, of course, for the patients, and we need to embrace those small wins too. Physical self-care, nothing new here. You know, your mother gave you the same advice. You got to eat, you got to sleep, you got to move. But it's still so important, and it's so easy to stop doing these things when we're busy. And equally so, mental self-care, whether it's breathing techniques, whether it's mindful meditation, whether it's something entirely different. I mean, for me, I think I would call myself more of a mini meditator, because mindful meditation is great if you can take 30 minutes every day, really embrace the practice. Certainly you can derive the most benefit that way. Some days you don't have 30 minutes. You've got 30 seconds. You're in between patients. So taking a few deep breaths, just filling your lungs with oxygen, closing your eyes, taking a few deep belly breaths, just slowing everything down can really be helpful. It's like a quick hit of meditation or relaxation, and it can go a long way toward grounding you in the middle of a hectic day. If you are in fact developing some of those later warning signs like we discussed above, then by all means, psychotherapy, psychiatric medication you could consider. You know, fortunately in this audience, we likely have pretty good insurance, so we have access to this kind of care. The meditation apps are great, doing your yoga is great, but sometimes we need something that is a little bit more individually tailored, a good therapist, a good counselor, a good psychiatrist, what have you. So we want to be open to whatever can help us. I want to, I know I went through a lot of time. I wanted to go through this quickly because I know my colleagues also have a lot of information to cover as well. So I'm going to take my slides down. I'm happy to take some questions now. I'm also happy to wait, and we can also take more at the end too. So I'm going to stop my share and hand it over.
There's one question here before we go on to our next speaker. Josh, so with regards to burnout, can you just comment on the incidence of anxiety and depression amongst physicians?
I don't know. I don't have statistics off the top of my head. I don't know that it is necessarily. Yeah, I don't want to. I don't want to take a guess right off the top of my head because, you know, I suppose it is possible for people to, you know, almost go from 0 to 60 and not have this protracted long course of worsening anxiety, worsening depression that maybe worsens for months to years and then, you know, ends in some tragic story of the two suicide cases. I think for physicians, you might not even see elevated rates of anxiety or depression despite the slightly higher suicide risk than the general population. But again, I don't want to speculate on numbers that I don't have access to at the moment.
It's an interesting phenomena about the statistics in physicians, really.
Yeah.
Thank you very much, Dr. Kurse. Our next speaker is Dr. Linda Reaver. Dr. Reaver is an associate clinical professor at University of Southern California in the anesthesiology and pain medicine section. And she is also chair person of the physician well-being there at the Keck School of Medicine. And she's a colleague of mine on the CalSIPP board. We welcome Dr. Reaver. Thank you very much.
All right, let me screen share. I'm going to share my screen with you. It's a pleasure to be here with everyone this evening. And I'm going to try to build on what Dr. Citron and Dr. Kurtz has already presented. I want to talk a little bit about self-care versus patient care and how to support colleagues today. Let's just go to our next slide. Hold on, let's go here. Okay, so I don't have any disclosures to share with you this evening. I did want to talk a little bit to build on sort of about us as humans, as physicians, and how we're particularly what our attributes are, and then how these can contribute to our vulnerabilities as we discuss burnout and how to support colleagues. Generally, we're very hardworking, we are detail-oriented, we're independent, self-reliant type people. We feel very responsible. We tend to be very compassionate, and we tend to be very altruistic and resilient. And I want you to kind of remember those last two items, being the altruism and resilience, as I say, because that's definitely an attribute I think that all of us share, particularly as physicians and providers. But we have some vulnerabilities that it kind of set us up for some of these problems that we're talking about, and how burnout and so forth affect us. And that is that we tend to be perfectionist. We're very goal-oriented. We're selfless. Additionally, I think most all of us still swear a Hippocratic oath when we graduate from school and say we're not going to do any harm. So we have a tremendous commitment and feel a tremendous responsibility to all of our patients. So these kind of all help set us up. So when we talk about trying to, provide ourselves self-care, we got to think of ourselves as human beings. And what do we need? Well, my colleagues, Dr. Cintron and Dr. Kurtz, already spoke about all the, common sort of things that we have heard much about with, nutrition, hydration, sleep, exercise, doing the relaxation, breathing, meditating, connecting with family and friends, trying to do that work-life balance type of thing. And we want to be able to express gratitude. But I think most importantly, we want to not apologize for your own needs. And you want to try to exercise self-compassion. That's what I really want to bring out here as far as our self-care. And I think sometimes that's really hard with the attributes and our kind of responsibilities that we place on ourselves. Because as they already talked about, and I'm not going to spend a lot of time on this, but there's so many patient care demands, and especially for us with pain physicians, as Dr. Kurtz spoke about, that, they're kind of unpacking a lot on us. They have a lot of needs, and we, through our selflessness and altruism, want to help them and take on a lot of that. So when we have multiple roles that we have to fill in our clinical activities, we have to work with the patients, communicate with them, educate the staff, communicate with them. We're kind of looked at as the leader, sort of all the problems come to us, and we have to get all these different people to work together and for the good of the patient, plus all the documentation pressures and the precision that's demanded, and the timeliness, as well as the reimbursement issues. And of course, now we have more patient satisfaction, social media kind of presence. You have to worry about what's your reputation there. Are you getting the patients through fast enough? What kind of reviews are they giving you, et cetera? And overall, a lot of production pressure. And the issue is that really this is a lot also that we take on ourselves, as well as the external pressures, as Dr. Kurtz said. So, we're constantly telling ourselves, we're going to be tough, we're resilient physicians, and we've been through a lot already, and we don't want to be a wimp. And so, and the administration is just going, stop complaining about all this. But we're still human and have to deal with that and how it impacts us. So I wanted to bring up another topic for your consideration that builds into this whole background and who we are as physicians, because we're challenged all the time with moral dilemmas, complex medical decision-making, ethical issues for patients. We start developing moral distress. This is an article from Dean Talbot and Kaplan in JAMA 2020, where they talk about that the we start developing moral distress because physician knows what needs to be done, wants to do the right thing, but may conflict with the institutional values or other administrative values or pressures. And so all this starts to accumulate. They call that a moral residue. And finally, if there's enough of these kind of conflicts, that it tends to develop into a moral injury, where they talk about that being an erosion of the physician's moral beliefs because of these multiple episodes of distress. So Dr. Zubin Damania, which I know some of you may have seen his Z-Dog YouTube and blog type materials, is very much concerned with, burnout. Really, is it a moral injury? And that's why it continues to increase and be so resistant to all of our efforts that we're trying to bring up tonight. So with that said, as a background, I want to talk a little bit about sort of another aspect that we're all involved with as practitioners, and that is of being a second victim. So this was originally described by Dr. Wu in 2000, and also has been contributed to a lot by Dr. Sue Scott, who's a doctoral nursing practitioner who has done a lot of work with patient safety and the second victim phenomenon, and how to help physicians and practitioners in that sort of scenario. So we talk about a second victim in the context of, if you have a patient that has an adverse event, or they experience a medical error, or there's a patient-related injury, okay, they're the victim. But then that physician or provider that was involved with that patient in that scenario is then considered a second victim, because they become traumatized by any of these adverse events, or even potentially a medical error. And as my other colleague said earlier, definitely with burnout, more likely that you could have increased medical errors. So with that in mind, I have a case discussion that actually I was involved with. And this was a 75-year-old gentleman who had a total knee arthroplasty under general endotracheal anesthesia. And that was after he underwent an uneventful placement of epidural catheter for his postoperative analgesia in the pre-op area. In the PACU, he was awake, but complained of numbness and weakness in both legs, and also in his arms, numbness in his arms. His coags were within normal limits. The epidural catheter was taken out, though, because he seemed to have this prolonged effect from it, and was not really having pain per se at his knee. He went urgently to an MRI, which initially was read without any acute changes or hematomas found. So he was transferred to the surgical intensive care unit and underwent neurology and neurosurgery consultations. His deficits continued, and the MRI was reviewed again the following morning, and again throughout the day, and the patient ended up being taken for a surgical procedure with a C-spine decompression by the neurosurgeon. However, there was no improvements in his condition. And incidentally, the patient himself was a lawyer, and his son was a urologist. So of course they were extremely frustrated, upset, and 1 year later a malpractice suit was filed. So obviously the practitioners involved in this case would be prime example of second victim. So how does this person, practitioner, feel? They may feel personally responsible for the event and the patient outcome, and they feel like they failed the patient, and they start to second guess their clinical skills, ability, and knowledge. So I'm going to explore that a little bit more and say that basically through the work that Sue Scott and others now have done with this, there's kind of a recovery trajectory that goes from sort of stage 1 to stage 6. And the first 3 stages of it essentially can all occur together. So the initial thing is the initial incident that happens. And you're basically very busy with trying to stabilize the patient, make sure everything's under control, no more harm is coming, take care of all those acute needs. And then you may start thinking about it again. So stage 2 is kind of your reflections about it, start reliving the event and worry and how could I have prevented this? What did I miss? What happened? Then you start thinking about trying to restore personal integrity, and you're sort of like, what's going to happen to me? What's going to happen to my job? Am I going to, lose my job? Finally, stage 4 is what you have to deal with, and can be very promptly afterwards, because that's when you may have to disclose what happened to other colleagues, and especially to the patient and their family, and continue to work with them, which is very stressful. And again, you kind of have a lot of self-doubt and concern. And in stage 5, hopefully you're going to be able to get a little bit of emotional support and first aid, which we'll talk about in a minute. And finally, stage 6, and that's considered moving on, but there's 3 sort of pathways potentially that could go. And that is that hopefully you're going to be thriving because you're going to get help and aid, which we'll talk about in just a moment. You're going to be surviving, which means that, you are kind of able to manage, but you're still struggling with a lot of maybe flashbacks, almost like a PTSD, some sadness, depression, or dropping out. So you may want to think about, am I really good in this? I'm going to drop out of clinical medicine. Potentially even people can start abusing substances, drinking too much, depression, and potentially even end up with suicide. So we definitely want to try to avoid that. Overall, we look at 60% of the second victim practitioners may require some type of peer support initially, and then 30% may require a peer support that has a little bit of extra training in how to work with second victims, and 10% may go on to require actual professional counseling and external support. So really, what are the victims, what are they needing, what are they looking for? They're looking for understanding, compassion, respect, and supportive care with, transparency. Obviously, we've all been through a bad case, and we're all concerned about what people are going to think of you, and the whispers and so forth, and as they, go through the QI process with something like this. So we talk about psychological first aid, and one of the psychologists that I work with at USC helped develop this, along with basic use of the WHO handbook. And I think it's important to stress kind of what the first aid is not. So when we're trying to aid a colleague, we don't want it to be another medical QI debriefing. We're not trying to give professional counseling or psychotherapy. We're not trying to get the physician to keep talking about the event and relive the event, and pressuring them to talk about it. And we're not trying to give advice. So what do I want to leave you with? What are we going to do to help our colleague that has a bad situation like this? You really just want to listen. You want to let them tell you what they want to tell you about the event. And you want to really focus on their, human emotional side and how they're dealing with this event, rather than the medical details of the incident. And you want to listen for clues that they're having a difficult time. I think, as Dr. Kurtz mentioned with some of those in his previous talk. You want to just note, again, are they having changes with their behavior or their mood, with their work performance, how they interact with their patients or other colleagues or staff in the office or hospital, how they participate in their activities at work. And also listen for what they're doing maybe away from work, and talk to them and kind of just listen. And are they drinking too much? Are they using substance? Are they having a struggle to, come into work and feeling like they don't want to come to work? All those sort of things are warning signs. So really, when you're trying to offer support to a colleague, you want to sort of just be there to listen, but also it's nice to start out when you right at the time of the incident, but it may take a while for the physician to process all this, and you want to be able to check back in. So, come back, a few days or a week later and be there to listen back and forth, and also potentially to help point them into some other resources. And maybe there's a second victim type response team, care for the caregiver, that sort of thing, at one of the hospitals or practices that you're at. So I think I'm going to stop there. Questions, and thank you all for listening. Any questions? I can stop screen sharing and I'll turn it back over to Dr. Citron.
Thank you, Linda. That was very informative. One question that came up with regards to the techniques that you've described, how do you maintain confidentiality, or what have you done in your institution that they're concerned about that quite a bit?
Yeah, so certainly we have a Care for the Caregiver program at CAC. We have what we call H3 team, or Helping Healers Heal, at the county side and that hospital of our campus. And so we have actually reached out and given a little bit more formal training to people that volunteered that wanted to be on this response team. And so they are all schooled in the fact that this is completely confidential, and that what the person tells you is staying between the two, and that you're not going to be involved in any QI process. It's not about peer review. This is to help the person and to be there to listen and to give resources. Certainly about some of the same resources that it's provided earlier if they need someone. We also have a Center for Work and Family Life or Employee Assistance Program that we would refer the person to if they need other more sophisticated professional counseling to go to. And does that help answer?
That's great. Thank you for answering that. We'll have some more questions at the end. We'd like to move to our next speaker, which is Dr. Steve Sartori, and he's coming to us from Kentucky. Dr. Sartori is the director of the Center for Wellbeing at the Christian Medical and Dental Association, and he is a certified physician coach and has been involved in teaching, in private practice, and has done a number of mission trips throughout the world. Dr. Sartori.
Thank you very much. I'm going to put my screen up in hopes you can all see that, if all is well. Great stuff, Linda and Josh and Lynn. Thanks for moderating, and thanks for inviting me. My part of the presentation is really designed, I think, to give us all hope, to say that when adversity comes, which it will, whether it's burnout, whether it's being a second victim, adverse clinical events, lots of things happen to us in life, both professionally and personally. We take a lot of hits just through the nature of living in a difficult world. And how is it that we can redeem those experiences and actually grow through adversity? So, hopefully at the end, there will be a sense of, this can actually be good for us in a strange sort of way. Even burnout can be used for good to give us information and help us to grow. I don't really have any disclosures. I do have some disclaimers. I'm not an expert in anything. I'm a family medicine doc. I've learned how to not be an expert in anything. And coaches, that just takes it to another level, because coaches are not experts on anything. The client is always the expert. So anyway, I am learning to take some of my own medicine, because adversity happened yesterday. Some of you read in the bio that I am a Green Bay Packers fan. And certainly I've had to take some of my own medicine here, adapting to adversity and saying, how do I grow through the experience? Some other quarterbacks also have gone through adversity. If you look at the book by Drew Brees, Coming Back Stronger, talking about someone who has weathered using the power that's found in adversity. If you remember the story of Drew, he almost didn't have a career at all. He was drafted, went to San Diego, had a major shoulder problem. They did some experimental, almost unique kinds of operation, trying to give him just hope and a chance at a career. And you know very well what happened. Here he is, 39 or 40 years old or close to it, and performing at a very high level. Many other people come to your mind as you think about adversity, as you think about people who have weathered great storms and have come out better on the other end. You know, I can think of Louis Zamperini in the book Unbroken, you know, a prisoner of war in Japan who comes back from war after being abused and just miserable and PTSD and all of that, but ultimately finds the power of forgiveness and moves into a space where he becomes a motivational speaker. You think of people like Bethany Hamilton, has her arm ripped off by a shark and returns to competitive surfing after she loses her arm. You think of Horatio Spafford, a Chicago businessman during the time of the Chicago fire, who's a wealthy lawyer, and the Chicago fire wipes out most of his possessions. He sends his family to Britain on vacation, and his 4 daughters die in a shipwreck en route to London. And as he goes to join his wife, he writes a song, It Is Well With My Soul, which is a very well-known song throughout the ages now. But these kinds of pictures of tremendous resilience and tremendous capacity to use adversity for good. Drew Brees in his book used this quote from Nietzsche that says, that which does not kill us makes us stronger. Now, I would say not always, not always, but it can. And there's a difference between how is it that some people respond to adversity one way and others another. The Chinese character, some people say, and I don't speak Chinese, don't know a thing about it, but the crisis represents a possibility of danger plus opportunity. And so I look at adversity as an informant. Adversity, what I call the university of adversity, it sheds light on what we treasure, on what we value, on what we think about ourselves, and what we think about the world. It's very informative. And when I think about adversity, it's not just getting through, gritting through. You know, doctors are really good at gritting their teeth to buck up under great pressure. It's not just about getting through or going through, but it's really about growing through. How is it that we actually grow psychologically in the midst of great difficulty? So in the few moments we have, I really just want to touch on well-being, because that's really a talk all to itself, but I'm going to condense it, not by talking faster, but by saying less. And resilience and adversity, and then a little chance to reflect, because each one in the audience is unique. There are no two of us exactly the same. So how I respond or you respond is not really necessarily how your neighbor will respond. So to think that we know someone else and how they're going to act or behave during adversity is not true. We have to be very careful. You know, there's a saying by Dr. Seuss, you are you, that is truer than true. In fact, there is no one else youer than you. So just remember that you're unique. Well-being is really a global thing. Burnout is really relates to your profession, but well-being is a global thing, a positive state of health that enables you to live up to your full potential, and it results in a deep sense of life satisfaction, as opposed to burnout. And Josh did the 3 that are classic. But the quote by Christina Maslach, who actually authored those original 3 markers, you know, that touches you, is this erosion of the soul. And the erosion of the soul, that hurts just reading it, caused by a deterioration of your values, spirit, dignity, and will. So there's really a continuum. You know, depression is not the same as burnout, although some people would argue that it is, but there's really a continuum on the way to well-being. Neutral being, I'm keeping my head above water. Depression, burnout, meaning I'm drowning. And well-being, meaning I'm riding the crest of the wave. It's a really great place to be. Martin Seligman, who's the father of positive psychology at UPenn, has authored several books about happiness, well-being, thriving. And one of his first books on authentic happiness, he sort of described different levels of how our well-being plays out. And a basic level, it's a positive emotion. Happiness means, you have a positive emotion. You're living for yourself. You're living for pleasure. Another level would be, I'm really doing something for other people. I'm really not just living for myself, but there's more to life than just me. And then level 3 would be, there's even more to life than just me and other people. There's really something even more meaningful that affects more than just me, just more than other people, but the world at large. It's a bigger picture of what well-being is. Because if you focus on pleasure and performance, and what happens when life isn't pleasurable anymore? Is it impossible then to have well-being? What happens when you can't work? What happens when you're disabled? What happens when things go awry? Does that mean you cannot experience happiness or well-being? I would hope not, because we know many people who experience well-being in the midst of great adversity. If you look at what they call the Harvard Men's Study, this is a longitudinal study of Harvard students, sophomore students, 1938. It was a men's school, no women at Harvard in 1938. They have studied these men who are now in their 90s, many deceased, and they said as they monitored, what is it that made these men report a life of contentment, satisfaction, and well-being? These were prominent men, high performers, CEOs, lawyers, doctors, business executives. And they said the thing that mattered most was the quality of their relationships, that happiness was only the cart, love was the horse, the quality of their relationships. Gallup does a study every year about happiness. They survey the world, 156 countries. They get the best of the happyologists together. I think that's a word, but they study happiness. And it's interesting, in 2011, the happiness report said that the happiest people in the world were from Nigeria. It was the happiest country. And the most unhappy country in the world was Romania. Well, interestingly enough, I happened to be in Romania when that report came out. I'm speaking to a group of medical students, mixed Nigerians and Romanians, because there's a bunch of Nigerian students at Iași at the medical school in Romania. And so I said, I have a captive audience. I said, give me some feedback. This report says the Nigerians are happy, the Romanians are not. What's that about? The Nigerians right away said, yes, we are the happiest people. We don't hesitate to go to our neighbor. We don't have to knock on the door. We walk in, we have conversations, we share meals. Everything is great. And the Romanians said, we don't trust our neighbor. We don't know who's going to report us to the communist authorities. We can't trust anyone. We are scared to death of everyone around us, so we don't have good relationships. So it seemed that relationships, just like in the Harvard Men's Study, so key to happiness, as reported that year in the Happiness Report. A review of the literature even shows this, that when you review the healthcare literature, the lessons of health psychology research, the secret to successful living. Here it is, the secret to successful living, 3 things: a sense of purpose, positive relationships, and healthy habits. Those 3 things are the markers. That's the secret sauce. It may be simple. It doesn't mean it's simplistic. Doesn't mean it's easy. It just means that that's what it is. And so if you look at the well-being grid and you say, okay, what is it here? Well, it has to do with how you look at yourself and treat yourself. It has to do with how you look at others outside of yourself and how you relate to them. And it has to do with what you think about life in general, the meaning, the purpose. So burnout, the red zone, that's not where you want to be. That's exhaustion, cynicism, futility. Work is meaningless, and you don't even want to go to work. You don't want to see another patient. You're totally exhausted. You can't get refreshed. Engagement means, work's going okay. You have some empathy. You're doing something important. But it's not quite the same as the fullness of life satisfaction, which is this deep sense of contentment, a deep sense of connection with other people, and a real sense of calling. And Frederick Buechner says that calling is where you have an intense passion that meets the need of the world. There's something in you that you want to accomplish, and there's a cry for it at the same time. It's a sweet spot where what you have to bring to the world is what the world needs for you to bring to the world, the sweet spot of well-being. So is well-being an inside job or an outside job? Josh mentioned what work can do for you and what you can do for you. And there really are both determinants here. But Sonia Lubomirsky from UC Riverside, she says that really, there is a set point. People do have a bit of a predisposition to whether they sort of really appreciate life or they look at life optimistically or not. And, there's a happiness set point. But circumstances really only affect 10% of your happiness quotient. So it's not what happens to you, it's how you respond to what happens to you that makes the difference. And Viktor Frankl, and many of you know his book, bestseller, Man's Search for Meaning, the greatest freedom is the freedom we have to choose. We can choose our attitude. Nobody can take that away from you, whether you're in a concentration camp in Germany or Poland or wherever. It cannot take away your freedom to choose. Abraham Lincoln said most people are about as happy as they choose to be. So what happens when adversity strikes? Well, several things happen depending on you or the person in the midst of the adversity and the intensity of the adversity. Trauma is a word that means it's just sort of a overwhelming stress. It's this life-changing, potentially life-changing stress. It's a level of stress that is just extreme. But in response to adversity, and we'll get into what resilience is and what it's not. And again, I'm not here to tell the doctors in the crowd here, buck up, get stronger. I'm just saying that this is the data that we're looking at. And so ultimately we'll say, what does it mean for me? But we can, in response to adversity, we can simply resist. We just hold the course. We just let it bounce off our shoulders. Nothing happens. We just keep going. Or we have this curve, the red curve, which shows we take a hit. We take a hit. And depending on the intensity of the hit and the capacity of ourselves to absorb it or to respond to it, we ultimately get back. We ultimately get back to where we were. We recover back to baseline. There's a third potential response, what I call the regress. That's the gray line. You take the hit, you kind of descend into, and you really stay stuck. You really stay stuck in this disorder, this PTSD, whether that's moral trauma because there was a moral hit, whether it was a traumatic, you're a war veteran and you happen to see people die and just bloodshed or traumatic things or rape or all the different things that people can experience, but you don't recover. That becomes a psychological problem that is not part of this talk because that's outside of my purview of excellence. Josh probably has a lot more information about that. And then renew. What can actually happen is that you take a hit, you respond to adversity, it takes you some time, but you recover. Not only that, you learn things along the way that actually improve your psychological well-being so that you reset your set point at a higher level. You're actually healthier. You're actually better off for going through the adversity. So these are a variety of ways we can respond. Resilience is those three responses. It says you can resist or you can recover or you can even grow through adversity. Now we know that our well-being is heavily dependent on what happens in the workplace. There's only 168 hours in a week. Of those, the average doctor works 56 hours a week. That is the normative average. Some of you work more, some of you work less. The hours are coming down over time. But if you think about that, 56 hours at work, 168 hours a week, that's a third of every hour you have. And if you sleep 8 hours a night, which is, by the way, not a bad thing to do, sleep 8 hours a night, that means you would sleep 56 hours a week. That means that half of your hours awake are spent at work. And if you commute or do other things, it's probably more than that. So a great part of our well-being is based upon what happens at work. And the Stanford model of professional fulfillment shows us that at work, resilience does count. Now, these three sectors are not proportional. They're proportional in the diagram, but they're disproportional in reality. The reality is that the culture that we live in as doctors. I mean, that bureaucratic culture, that governmental culture, that organizational culture is heavily important, just heavily influences, how we respond and our well-being. And then the next sector is this, what I call the context. So you got the culture, the context, and the capacity. But the context is what happens that's closer to us, our team, our staff, the people we work with in the OR, the people we work with in our clinics. That's an area that we can affect. We have some influence there. We have very little influence in the cultural domain, unless we're a leader in a healthcare organization. We have more influence in the practice domain, the context, and the personal resilience is where we actually have the most impact, although the leverage there may not be quite as great, but it is important. Southwick and Charney, psychiatrists from New York, studied resilience, wrote the book Resilience, and identified the factors that seem to be associated with resilience. They came up with 10 factors. If you look at them, they fall into 3 major categories. This is my way of simplifying things. As family doctors, we try to make things very simple. So this is my way of simplifying things, what I call the 3 R's, not reading, writing, and arithmetic, but the 3 R's of resilience. So routines, and we talked about that. Josh talked about that. What do we do for ourselves? We all know that, relationships and religion and spirituality. So the 10 things that they discovered are all listed there under one of those major categories. Now, they're not perfect matches necessarily, but in general, they do fall into one of these 3 categories, just like that research slide I showed earlier that talked about purpose and relationships, right? How we take care of ourselves, our routines, our relationships, and our religion that have to do with well-being. So how do we make good relationships? Well, I wish it were just easy to give you a formula. How do you make good relationships? We do know some things. If you pay people, they like that, right? If you pay attention, you be present. You're not looking at your phone. You're not doing something else. You're paying attention. The gift of attention. People don't get much attention anymore. Everybody wants your attention, and there is more distraction than ever before. Listening. Rather than talking, listening just to understand, not to respond, not to tell someone what you think, but just listening. Acceptance, the power of acceptance, regardless of the differences you have, regardless of your political views, your religious views, your financial views, your specialty. Can we just care about one another because we share humanity? That's a hard thing to do, isn't it? It seems like that doesn't happen very often in our country today. What about forgiveness? Unforgiveness is one of those things that you think you're hurting someone else and you're actually hurting yourself. It's like taking poison, hoping the other person's going to die. That's unforgiveness. Louis Zamperini in that book Unbroken had to discover that he had to forgive his tormentors of the Japanese guards who were just absolutely tormenting him in prison in Japan. And trust. Trust is a key. How do we build trusting relationships? A firm belief that you can trust someone. They're reliable. They're strong. They're dependable. You can share things with them safely, that trust factor. And one of the drivers of burnout, according to many studies, is, and Josh referenced it, a lack of respect. Well, what it comes down to a lot of times is an erosion of trust. There's an erosion of trust in the relationships in the workplace. Do you trust the administrators have your best at heart? Not always. You have conflicting values. So what does it take to build trust? Francis Fry at Harvard, in a webinar called Unleashing Greatness in Others, talks about the triad of trust. Authenticity. Are you who you say you are? Are you an imposter? Are you putting on your armor? You got your face. In COVID, we see people with face masks, right? I didn't even know Linda existed without a face mask. Every time I see her, she had a face mask on, So can we take off our mask? Can we take off our armor? Can we be authentic and vulnerable people? Brené Brown talks a lot about that. And what about empathy? Can we connect with other people at an emotional and a thought level that we really care about them? That's empathy. And logic. Can we really communicate effectively and accurately and honestly? And your reasoning and your judgment are good. Trust is key to building relationship. In fact, Patrick Lencioni, a business consultant, He wrote the book called The 5 Dysfunctions of a Team, which some of you have probably read. But it leads to the opposite of dysfunction, which is the 5 disciplines or behaviors of a cohesive team. And he stresses over and over again that trust is the absolute fundamental building block of relationships in the workplace. And when we talk about peer support and collegiality, who is a doctor going to go to when they're in trouble, when they've had an adverse clinical event, when they're burned out, when they're not behaving right and you notice it? Who are they going to go to? They will not go to the mental health professional right out of the chute. They will go to a colleague. They will go to a colleague. And it's up to us to notice it and to not be judgmental about it, but just to notice it, just to observe it and to bring it to their attention. Trust, so critical, because if you have trust, you can have conflict in a healthy way. You can conflict around ideas. You can conflict around the meritocracy of ideas, not politically, but just ideologically. You have great conversations if you trust one another. Religion and spirituality is very good for your health. Better physical health, mental health, longevity, well-being, happiness, meaning, purpose, hope, optimism, relationships, proven over and over and over again. 326 studies show higher well-being, generally hundreds of studies. This has all been studied by Harold Koenig at Duke, who has done a meta-analysis of all of the studies. Very rarely does religion or spirituality work against you. It generally works for you. 80% of people, when you ask them about religion and spirituality, they claim them to be the same. They don't differentiate. But 20% of the people say they're spiritual, but they're not religious. So it doesn't necessarily mean you attend a church or you have a certain denomination. It just means that you're attentive to those kinds of things that matter, that are existential, that are transcendent. The search for the sacred that occurs sometimes, in fact, often in the context of established institutions. It's a sense of awe. We miss that so often. We're so busy. Doctors are so busy. We miss a chance to simply look at the mountain, the snow, appreciate the rain, smell the flowers. There's a sense of awe in the universe around us that we miss. I am just one of the least observant people around me. My wife has to bring to my attention when we're on a hike. She has to say, "Do you see that caterpillar there? Do you see the way that leaf looks?" And I'm just destined to get to the end and get my exercise in. And she wants to stop and notice along the way, a sense of awe. C.S. Lewis says there's a sense of awe and wonder, and there's also a moral compass that seems to be related to that sense of awe, which leads to identity, purpose, meaning. What is it that drives us? What's important? And these folks who wrote a book called Burnout, meaning the nourishing experience being connected to something larger than ourselves. And Viktor Frankl, once again, he says, life isn't unbearable because of circumstances, but it becomes unbearable when there's no meaning and there's no purpose. He said the people who did well in the concentration camp were those who had hope and a sense of meaning, and someone who loved them. Those are the keys. And if you have something to live for, you can bear almost anything. Friedrich Nietzsche. Simon Sinek calls it, what's your why? Know your why. So what happens as a result of adversity? Well, post-traumatic growth can occur. Tedeschi and Calhoun studied this. It's a positive change, a positive psychological change. Remember that curve we showed earlier that happens in the wake of struggling with challenging life circumstances, oftentimes even overwhelming, temporarily, life circumstances. And what happens as a result is there an increased sense of gratitude and appreciation. You just learn to pay attention to what you have and appreciate what you have. Not always longing for what you don't have, but appreciating what you do have. There's increased perseverance, the capacity to say, I got through this. And I have confidence that when the next hit comes, I will also have the strength to move through it. There's a sense of optimism. What did I learn? What did I grow? How did I get better as a result of this? Now, these things don't come necessarily at the beginning. And remember, Linda, even going through those stages of what happens, you don't get to stage 6 right out of the chute or whatever. It takes time for us to process these things. Better relationships, more attention to what is important. What are the priorities? What is the meaning of life? The big questions, and sitting there and just reflecting on those things. What are the big questions of life? So ultimately, The Japanese pottery kintsukuroi says, if you're broken and repaired, you're actually more valuable than you were in the beginning. So there's something about a life that's traumatized or goes through the fire, so to speak, coming out on the other end better than before, better than before. I'm not really telling you to just run toward adversity because you're going to be better than before. I don't want to give that impression, but it can happen better than before. So now you have to ask yourself some questions. Those of you here in the audience, ask yourself, this is a personal time to say, okay, what is my experience? What have I learned? What have I been listening to here with Josh and Linda and Lynn and Steve? What's been going on? And so what? I mean, am I just here to listen to a webinar and knock this off my list, check it off my list? Or am I here at this webinar because it's intended for something to happen? It's intended for me to pay attention to something. And if so, what am I supposed to pay attention to? And now what? At Johns Hopkins, as they've been going through COVID and dealing with moral distress, they have a lot of nursing people who are experts in moral distress at Johns Hopkins. And so they've developed resilience rounds, moral resilience rounds, a chance to join together and people in a psychologically safe place to discuss the kinds of questions that matter as they process difficulty in a safe place, an accepting place, and very, very important stuff. So a few questions that might prompt your thinking. What's my experience? Everybody's COVID experience is different. Some people are furloughed. Some people are working extra. Some people are working from home. Some people aren't working. Some people are richer. Some people are poorer. I mean, a wide variety of things have happened to all of us, and it's all unique to us. And what do I appreciate more? And what has this made possible? We've all learned something through this. I learned things about Zoom I never had a foggiest idea about before. And I still have much to learn, but there's just what has been possible. We're pretty resilient people by nature. We come up with solutions when things get going tough. It makes us come up with something, and we really rise to the challenge. What have I learned? What have you learned even in these few moments? What have you learned from COVID? And what have you learned about yourself, not just the circumstances? What's important to you? What are your priorities? What have you rearranged in your life? What are you going to keep that's rearranged in your life? What are you going to change in your life? What are you going to get rid of as soon as you can when COVID is over? And you can go back to the restaurant, or you can go back to your church, or you can go, looking forward to that. What are you hoping for? And what changes could you make? And not only could you make, but it takes a commitment. What change will you make? And who will you tell about it? Because when you tell someone you're going to do something, you have a much higher chance to do it. And really the key here is to say, that serenity prayer that my good friend, a chief medical officer here who I have lunch with, or used to have lunch with almost once every couple of weeks, he has it posted, God grant me the serenity to accept what I can't change. There are some things you cannot change. Why beat your head against the wall when you can't change it? But there are some things you have influence in. Then have the courage to change it, but have the wisdom to know the difference. Where are you going to invest your energy? Energy is limited. If we expend our energy trying to conquer things or change things that we have very little possibility of changing, that will be frustration. The gap between expectation and reality is frustration. So if you expect you're going to change something and it doesn't happen, you will live in a realm of frustration. So, but I do believe that healthy doctors who are experiencing well-being on a global sense bring a great influence into the healthcare marketplace and the capacity to advocate for the kinds of changes that will make all of our lives better. So the healthier we are as physicians and healthcare professionals, the better opportunity we have to be influential and to help the system. So I work with a great team, Ann and Ken, just two of my best friends in the world, who are on our coaching team. Coaching is one of the tools that there are for how to help people come to the realization of some of the things I've been talking about. There'll be some resources. You'll have access to the PDF afterward, plenty of references. I've got literally hundreds and hundreds of references, but I just put a few there. And thanks for listening. And I'm going to turn it over to questions and Lynn, and I'm going to stop my sharing and hopefully get out of the way.
Thank you, Steve. That was excellent. And wow, so much that we can learn through the COVID experience. There was a question that came up, and a few questions for all of our speakers. So we're going to take a few minutes and then have our sponsors speak. And this is for Steve. Can you tell a little bit about how to improve connection and relationships when we're under the COVID restriction?
Thank the good Lord for Zoom in those kinds of cases and other ways of virtually connecting. Telephones still work, FaceTime still works, Zoom still works, and staying connected is critically important because the tendency is to kind of move into our own little universe and not stay connected and lose some of that capacity. But as you heard from multiple places along the way, peer support, collegiality, Mayo talks about the casualty of collegiality, which has happened even apart from COVID. We already had declining collegiality because we don't have the same doctor's lounges. We don't have the same free time. We are so burdened, overloaded. We hardly have time for a conversation in the hall before we think we got to go on to the next thing. So be intentional about building these relationships. Reach out to someone on Zoom, on FaceTime, text message something. AMA has a program called Peer RxMD, which is a way to connect with people. If you don't have someone locally and you want to connect with a peer or a colleague, Peer RxMD, a friend of mine or an associate of mine or someone I'm familiar with, Mark Greenewald, has started that program. He's a family doctor in Roanoke, Virginia. Great program, great program.
Great. And then another question for you, Steve, is regarding resilience. And do you think that those of us that have survived this pandemic will be more resilient for the next crisis that comes up?
We hope and pray so. It depends on how we redeem this experience, right? If we just kind of march on through and simply get back to normal as quickly as possible, and instead of a new normal, a new set point, and actually harvest the growing opportunity, we won't be better prepared for the next time. But if we take some of the principles and we appreciate the deeper meaning in what we've gone through, I believe that yes, those of us who go through this will be better prepared. Every little thing you go through in life seems to be preparing you for the next thing that occurs in life. That's just how life works. We have an accumulative experience that takes us forward. And so I think, yes, for the most of us, we could very well be better prepared. Very
good. And this is a question for Dr. Kurtz. And Josh, we were talking about burnout, and the question is regarding how do you recommend that someone approach a colleague that we suspect is dealing with burnout?
That's a great question. I don't think there's a right or wrong answer. I think, certainly pointing out what you see, there's nothing wrong with that. If you see one of your colleagues and they're showing some of those early warning signs we talked about, they're not calling people back, they look like they're a little, neglecting themselves. Nothing wrong with that. Just saying, you're doing okay. You seem a little preoccupied. After that, you kind of put the offer out. Maybe it gets rejected. Maybe it gets accepted. If accepted, then moving into more of a listening phase. If you're really concerned about the person, then trying to suggest some ideas for them, be it talk therapy, be it talking with a psychiatrist or a therapist or a counselor, but gently. I mean, it's kind of a gift if somebody comes to you. So we want to be as respectful of that as possible. And maybe that's all they want. They just want to talk with a colleague. They don't want to be pushed into, you have to go meditate, you have to go see a therapist. Maybe that's all they need, is just the collegiality. And then you just take it from there. It just depends on the content, how they're doing.
Very good. Very good. Any other comments from our speakers before we move to our sponsors? There was one comment here from Dr. Harpley regarding mindfulness. and his first name's Thomas, that it doesn't necessarily require 30 minutes mindfulness. It can simply involve noticing something in the moment, like one's breathing, or something to see or touch or hear.
I absolutely. I think, when we're trying to teach these kinds of techniques to patients who are suffering from anxiety disorders or pain management, certainly we're really trying to get them to set aside, not necessarily 30 minutes, but to set aside 10 minutes in the morning, 10 minutes sometime in the afternoon or evening, and to really shut out the rest of the world. And often they might use a relaxation tape or a mindful meditation script. And that, frankly, it might not be realistic for a very busy physician to do that kind of dedicated, structured practice. And that's what I meant when I was referencing myself earlier, saying I'm kind of a mini meditator, because I think what I'm trying to do really is just do exactly what Dr. Harpley is mentioning. Slow things down, slow down my breathing, slow down my thoughts, slow down my speech, slow down everything. And sometimes just 30 seconds can go a long way. Like I said, it's a quick hit of meditation, and I think his point is a very good one.
Very good. All right, thank you, Josh. And Steve and Linda, very good discussion here. And again, this will be recorded and will be listed on our website, and we'll have the link shared with some of our groups that are participating tonight. We'd like to have a word from our sponsors. First of all, we have Valley Health, Maddie Crescendo. Maddie.
Hi, Dr. Cintron. Hi, everybody. It is we're truly thankful to be able to support and to be able to contribute to this webinar. A lot of great subject matter. We're just thankful to be able to support it, and hoping in a few minutes here, as we get to share a few things about Valley Health and our solution, that you'll find value in it. So my name is Maddie Crescenzo. As Dr. Cintron mentioned, I'm a founding team member of Valley Health. We are a healthcare digital marketing platform company, and we specialize in supporting physicians and connecting patients to looking for doctors online across various sites like WebMD, Vitals, Google, and all the different health review sites. But really the crux of this conversation in the brief time that we have here that I wanted to share is how much of your online presence do you control? And what's really, it's remarkable. We did it in our system and in our software across 35 plus sites, including the most visited ones in the world for health information, WebMD, Vitals, Health Grades. Over 5,200 physician profiles, 78% of the information about doctors and clinics information is wrong. So if you search yourself, you Google yourself, you look up your WebMD, your Vitals profiles, physician profiles, are they claimed? Do you have control of them? And so the key here is when your online reputation is left to chance, there'll be things like there'll be a profile silhouette picture. It won't be an updated picture. We even see competing practices and physicians that run ads on those profiles. And on WebMD, which is the most visited health information site in the world, 1 in 4 US adults visit WebMD. Over 1 billion traffic visits were there in 2020, and that's only really skyrocketed due to COVID. We, in our solution called Launchpad, we have a special program exclusively through WebMD and through Vitals, where we run physician ads with accurate physician information on those profiles to connect patients looking for doctors. And here's the other thing that's really that we've seen in the past several years: when online reputation is left to chance. We have a lot of experience in the pain specialty. We see not just chiropractors, but other specialists running ads on physician name, on a practice's name, on an institution's name. It's very common. This is done in Google Ads. But again, if this is something where online reputation is left to chance, these are the things that happen. Another case in point, if you search and Google your name or your practice or institution, There are Google My Business listings that show up on the right-hand side of search results. If you've moved locations, it may say permanently closed. Again, these profiles are automatically created by these software systems, by these sites. Whether or not anybody at your institution or you've created them yourself, they exist. So online reputation is entirely distinct from clinic reputation, right? So it's really key to be able to have control of this. And another thing that we've found, and we have up to 7 years of data on doing this for the largest pain practice in the country. You may think Yelp is just a site, right, for restaurants, right, and searching for local restaurants. We have data that shows how Yelp profiles and consumers and patients looking there, it's a great new patient referral source. And again, another example, as you can see here, profiles are left unclaimed and unmanaged, and other competing practices can run ads on those profiles. So with Launchpad and our technology, it helps shore up, clean up all that information across a network of 35 plus different sites. That's phase one. That happens within 30 days, and we ensure data accuracy. Phase two after that is really helping to increase ratings and reviews. And our software does a quick 5-star survey for a patient to rate his or her experience. We've generated QR codes, which get scanned right after a patient has a visit. And that pulls up this quick single question survey. And if it's a 4 or 5, we're able to share that and out onto WebMD, Vitals, and all these key sites, Google. If it's less than a 4, we route that patient feedback internally. So it's a great mechanism for the patient's voice to be heard. And then lastly, one of the key points that differentiates our Launchpad solution is that we generate unique appointment request landing pages, but we are able to measure the return on investment even from this starter Launchpad program. We know exactly where new patient referrals came from WebMD, from Google. We can quantify it. We know the cost to acquire those patients. And so we believe and know that this is a differentiator, and it really helps support physicians in allocating marketing resources, especially if those resources are limited, to be able to demonstrate and measure return on investment. The simplest way to think about Launchpad and what we do at Valley Health is it's a do-it-for-me service. It's the opposite of DIY. We're essentially the mission control, where in one place where you can input physician information, and we propagate all those updates across 35 plus different sites, and offer other support solutions as well with digital technology. Again, we're truly thankful to be able to support this webinar and be a part of this. And so really the place to start, we've created a quick little page for you here at connect.valleyhealth.com/CalSIPP. There is a special offer and a special rate that is just for CalSIPP members. And also what we'll do is generate a free report card per physician, walk you through the insights, and we want to bring value and serve in whichever way we possibly can. We've seen, to Dr. Sartori's talk, we've seen significant adversity when it comes to technology and all these profiles and the complication of managing all this with technology, but it's our calling. It's what we feel like we were made here as servants to be able to support in whatever way we can. Thank you again for your time. We appreciate it on behalf of Valley Health. Thank you.
Great. Thank you, Maddie. That was very informative. And we look forward to hearing more about the technology and the developments. Obviously, everything's gone digital these days. Our next sponsor is Medtronic. So we have a brief little video, and then we'll get to Edwards with Charles. thank you very much, Medtronics, for your support. And we'll have some more connection with them through our website. Our next sponsor is Charles DeGao from Edwards Life Sciences. And thank you very much, Charles, for hanging in there. Please tell us a little bit about your sponsorship.
Sure. Thanks, Dr. Cintron. Thanks for having me. I'm going to share my screen real quick. I also really appreciate this topic. Before I worked in cardiac, I was a psychiatric nurse for 3 years, and this affects us all, especially during this time. I work for Edwards Life Sciences. I'm the clinical specialist in the Bay Area. So I work in the critical care division. So our Swan-Ganz catheter, all of your A-line transducers we make. There's a lot of different other non-invasive products. I just want to kind of give you my contact information. I don't want to take up too much time. But we have a new platform that essentially runs non-invasive A-lines, non-invasive swans. We make our swans, we make NIRS devices, we make oximetry products. Essentially, we want to make less invasive versions of our Swan-Ganz catheter. We've built predictive technology, artificial intelligence into our products now. We're one of the few companies that reinvests a lot of our money back into research and development to give clinicians like yourselves the newest technology they have to offer. Stanford actually owns our new platform, which in another month will run our non-invasive A-line. So I just wanted to kind of give you guys my contact information. I'm one of many specialists across the country. You can email me. Our website, edwards.com/critical care, also gives a pretty big overview of everything that we have to offer. We're in pretty much every hospital in some way or another, whether you're cardiac or you're taking care of ICU patients or you're getting a new heart valve, we're here for you. So we just wanted to say thank you for including us, and hope you guys have a great CalSIPP meeting. Thanks.
Thank you very much, Charles. And just a shout out to your company and the role that you've all played in during the COVID pandemic. And a number of my colleagues have been repurposed out in the ICUs and critical care over the past 8-9 months. And I think it's fantastic that technology can help improve survival. So thank you very much. I think that's going to be it for everyone today. Thanks again for those that were able to attend with your busy schedules. Feel free to forward any questions to us. Again, the point here is that you're not alone. I think it's been reiterated many times about the resources that are available. We can't do it ourselves. We need each other. So do feel free to reach out, and thanks again for attending.